Hello, everyone. Thank you for standing by, and welcome to our webinar, Parenting Prematurely, What to Watch Out For Before and After Birth, sponsored by IsisParenting and presented by Dr. Adam Wolfberg, Dr. Jason Carmel, and Dr. Kelly Lowry. My name is Chris Just. I'm the Executive Director of Prenatal Education here at ISIS, a certified nurse midwife, and your moderator this evening, along with Nancy Holtzman, VP of Clinical Content, Pediatric Nurse, and IBCLC, who will be typing with you in the chat room. During the presentation, all participants will be in a listen-only mode. However, you may submit questions to the speakers at any time by typing them through the chat feature located to the left of your screen, or direct them to us on Twitter using our handle at ISIS_parenting. We'll also take questions at the end of the presentation. Today's webinar is being recorded, and all of you will receive a link to the recording early next week. So if you missed something or need to step away for any reason, that's okay. IsisParenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. And as I mentioned before, I'm Chris Just. I'll be your moderator tonight along with Nancy Holtzman in the chat room. And now it is my pleasure to introduce our presenters for this evening. Dr. Adam Wolfberg is an associate at Boston Maternal Fetal Medicine. Dr. Wolfberg specializes in prenatal diagnosis and prevention of preterm delivery. His first book, Fragile Beginnings, was published in February 2012. He has written on health-related topics for many publications, including Slate.com, Newsweek, the Boston Globe magazine, the Huffington Post, and many others. Dr. Wolfberg will be speaking today on prenatal care as it relates to prematurity, including risk factors, cervical length, and therapy to prevent preterm delivery. Our second presenter is Dr. Jason Carmel. He's the Director of Motor Recovery Lab and the Director of the Early Brain Injury Recovery Clinic, Burke Medical Research Institute in White Plains, New York. He's Assistant Professor, Neurology and Neuroscience in Weill Cornell Medical College. Dr. Carmel's work is focused on the recovery of motor function after injury to the central nervous system using activity-based therapies. Dr. Carmel will be speaking on the 0 to 5-year-old, including brain development, the link between preterm delivery and brain injury, and therapy for brain injury. Our third presenter is Dr. Kelly Lowry. She's a pediatric neuropsychologist in Newton, Massachusetts. Dr. Lowry specializes in the assessment and treatment of children and adolescents with learning, attention, and developmental disorders, with particular expertise in managing complicated medical histories. Dr. Lowry will be talking about school-age children and focusing on learning disabilities, ADHD, and language impairment. And now, Dr. Wolfberg will begin his presentation.
Thanks so much, Chris. It's really a pleasure to be with the ISIS community this evening. I'm going to start by talking about the prenatal factors, about pregnancy and risk factors for preterm delivery. And I know that there are lots of new parents in the audience this evening, and I'm going to focus mostly on risk factors for another pregnancy, and for those out there who are listening and who are pregnant or are thinking about becoming pregnant at some point, these are some things they can think about. You know, the most important thing I think to keep in mind if you've had a preterm delivery is that it just happens. And it's really important for women not to blame themselves and to think that perhaps they did something that caused a preterm delivery or could have done something to prevent it, because it's almost never the case. Preterm delivery happens. We deal with it as clinicians, as parents, and blame serves absolutely no useful purpose. But let's talk about some risk factors, and these are useful for patients who are thinking about getting pregnant or who are pregnant, and particularly for those who've had a preterm delivery and are thinking about another pregnancy in the future. So the most important risk factor for preterm delivery, like so many things in medicine, is a prior preterm delivery. Depending on the gestational age at which the preterm delivery occurred, early preterm deliveries are a much greater risk for preterm delivery the next time than a preterm delivery at, say, 35 or 36 weeks. And also the number of preterm deliveries that an individual has had increases the risk of a preterm delivery next time. The reason it's important is that if you have had a preterm delivery before, it's really important to talk to your doctor or your midwife about that history so that you can do everything that's available to prevent a preterm delivery next time. The other, really the most important factor besides history is the short cervix. And this is a busy slide, but I think it's a really interesting one. And it comes from a very interesting paper published in the New England Journal of Medicine in 1996. And what it shows is, with the bars that are getting longer going toward the left, is that as the cervix gets shorter, and we're moving here toward the left, the risk of preterm delivery goes up. So this is a cervical length of 1.2 centimeters, and you can see that the risk is nearly, really more than 10 times the baseline risk. And that has led us as obstetricians to pay a lot of attention to the length of a cervix during a pregnancy and to, fortunately, resort to treatment in the event that we find a short cervix. And this is something that you can do. This is something you can do by reminding your clinician to check on the length of your cervix through the early and middle parts of your pregnancy. Let's talk about risk factors you can control. And some of them are sort of obvious. Smoking is bad in any part of your life. It's particularly bad if you're pregnant. Smoking impairs the development of the placenta, and it's a risk factor for preterm delivery. And the more you smoke, the higher the risk. So obviously, if you're thinking about being pregnant or you are pregnant, stop smoking. Drug use, having a very low having a very low weight yourself, or having a really high weight yourself before you get pregnant also modestly increases the risk of preterm delivery. And having a very short period of time between pregnancies can increase the risk of preterm delivery. These are all minor risk factors. These increase the risk of preterm delivery by any place between 10% and 50%. They're not major factors, but there's something you can do because all of them are within your control. Let's talk about some risk factors you can't control. So if you've had a procedure on your cervix, a LEEP procedure or a cone procedure, it needed to be done in order to protect yourself from cervical cancer. It's a risk factor for preterm delivery. It's a good thing to know. It's a good thing to let your provider know, but obviously there isn't anything you can do about that. And then other things that occur during pregnancy are also completely outside your control. There's nothing you can do about it. But if you have bleeding, if you have a urinary tract infection, if you have bacterial vaginitis, or if you have tooth disease and have an infection where you need to see your dentist, these are also risk factors for preterm delivery, and you just need to bring them to the attention of your caregiver. So what can you do? Because that's really all that matters. There are a lot of things that are outside of our control, but these are some factors or these are some actions that you can take if you're thinking about becoming pregnant or you are pregnant that may reduce the risk of having a preterm delivery in this pregnancy. So first of all, know your risk factors. I've gone through them. They're widely available at places like the March of Dimes. And if you have a risk factor for preterm delivery, make sure your doctor knows about it. The second thing is know your cervix. And I'm going to talk a little bit more about that. So like I said, if you have risk factors, particularly if you've had a preterm delivery before 34 weeks, make sure your doctor or your midwife knows about it. They may want to consider a consultation with a maternal fetal medicine doctor. And if you've had a prior preterm delivery, we now know that weekly injections of progesterone can significantly reduce the risk of preterm delivery during this pregnancy. It's really great news. We have for decades not had an intervention that was effective, and now we do. as evidence has mounted that the short cervix is a risk factor for preterm delivery, and of greater importance that we have a treatment for that, we as obstetricians have started to screen women for having a short cervix or for developing a short cervix during the first and second trimester of pregnancy with ultrasound. And I think that while there's been some controversy about whether that's useful, I think it's ready for prime time. I think it ought to be done. I don't think everyone needs a vaginal ultrasound, but over on the left here, you'll see this is a picture of a transabdominal ultrasound. It should be done in the second trimester to evaluate the anatomy of your fetus. And at the time, the sonographer doing the study and the doctor reviewing it ought to be sure that they can determine that the cervix is of normal length. They don't have to measure it. You can't really measure the cervix abdominally, but they ought to see that the cervix is long and closed. And if they can't, then you should really ask that you have an endovaginal ultrasound. And that's what this picture is over on the right. You can see the ultrasound transducer, this black half circle, pressing up against the cervix. This is the inside of the cervix here, the outside of the cervix here, and you can see this is a nice long cervix. But you should have some assessment of your cervical length during the late first trimester and through the second trimester when you have an ultrasound done for another reason. The reason is that if a short cervix is diagnosed, we know that vaginal progesterone reduces the risk of preterm delivery in these patients. So it's another risk factor that we can do something about. Now, I'm not going to go into the issue of cerclage because it's complicated and controversial, and while many of us think that in properly selected patients, a stitch around the cervix can prevent a preterm delivery, the progesterone is the easier, safer, and more universally useful treatment. So let's just stick to that for that on this topic. If you're concerned, if you have questions, particularly if you should end up with a short cervix and you feel like all of your questions have been answered, you should ask your midwife or ask your doctor to answer them, and if not, get you a consult with a maternal fetal medicine doc. So that's thinking about preterm delivery and thinking about things that you can do to prevent a preterm delivery. I'm now going to turn it over to Dr. Jason Carmel, who's a specialist in newborn brain injury and in pediatric neurology. Jason's also an old friend of mine and was gracious enough to work with me on the development of the book Fragile Beginnings. So Jason, take it away.
Thanks very much, Adam, and thanks to the ISIS community for inviting me to speak here. I can imagine that of the participants on the line, many will be parents of premature children who want to know, how is my child going to do? And that's a conversation that you will have with the people taking care of your child in the NICU, your pediatrician or developmental specialist afterwards, your child neurologist. I can't, there are many permutations and combinations, so we're going to have to sort of stick with sort of overall themes. But the overall message that I want to send to people is that babies develop their brains well, even if they are out of the womb early. And even if your child does experience brain injury, there's quite a, the brain has an enormous capability of healing itself, and that there are more and more treatments that we can offer in terms of helping to promote normal development. So with that in mind, let me just take you through this slide. So I know most people are unfamiliar with looking at brains, but here we see the picture of the human brain in a premature child, and on the left here, and on the right is at term. So the changes that I want you to focus in on here in the baby here has a relatively smooth outside of the brain. This is called the cortex. This is the thinking part of the brain. And the brain here is much more complex. So this might be akin to sort of a monkey brain in terms of being rather smooth and unsophisticated, and this is what allows us to be human. This folding of the cortex that allows for language, sophisticated hand use, other things that make us uniquely human. So during the period that a baby is, a premature baby is in the NICU, this very complex developmental brain processes are happening. So we, as child neurologists, are quite brain-centric. We see the NICU as allowing the child to breathe, to feed, all to support this incredible process of brain development that's happening. And we know that the ability of the other systems, your heart, your lungs, feeding and nutrition, are really great predictors of brain health and brain maturity during the early postnatal process, development. So I think that I can't, although most premature children are going to develop normally, we do know that brain injury, prematurity is a risk factor for brain injury. So this is a slice of the brain as if you were cutting off a baseball cap, and the brain has this cortex on the outside, and then some fluid-filled spaces. And this white part here is abnormal. This is an injury to the essentially the wires that connect the brain cells to one another, and those wires are connected with axons that have essentially rubber wiring on the copper wire, and so this interrupts those normal brain connections and can impair function. Larissa, who's Adam and Kelly's daughter, had a different type of injury. She had a bleed, and I'm circling the dark part of the brain here. This is also a risk factor for a type of brain injury that premature babies are at risk for. So these are either the connection injury, this white matter injury, or the bleeds are two of the brain injuries that premature babies are at risk for. Again, this is in the vast minority of kids, and when Kelly gets on later and discusses things like attention deficit or learning problems, generally the sorts of very subtle developmental problems in brain structure and function don't show up on the MRI, and that's not the sorts of things that we're talking about here. For those who may have brain-injured children or know of families with brain-injured children, one measure that provides a lot of hope is that the brain naturally heals itself. So, for instance, the left half of the brain normally controls language, and we know that kids with damage to the left half of the brain rarely develop significant language problems. So the right side of the brain can, in those circumstances, take over that lost function. In the case of Larissa, who's Adam and Kelly's daughter, who is profiled in the book, she had one of these bleeds, and she had, in an adult, this might cause a really terrible paralysis on one side of the body. And kids with that type of injury, generally, they can have impairments particularly in the hand function, but they are able to do things like dress themselves and do other self-help skills. So injury to to the developing brain can be compensated with normal repair processes. So when a child is born premature, people have thought a lot about how do we support this normal brain development. And in the neonatal unit, the idea is to keep a dark, warm environment similar to what they would have experienced had they been able to stay within the womb. And there's interest in skin-to-skin contact, the so-called kangaroo care between a parent and a child, eliminating as much as possible the interventions. The neonatal unit can be full of checks to the baby, sometimes drawing blood and other things. Those are in many cases unavoidable, but to the extent that procedures, for instance, can be batched and other things, caregivers have thought about trying to reduce the stress on the baby. And then there's the normal sort of sensory stimulation of cooing at your baby and holding your baby and patting them or rubbing their bodies, which facilitates sort of sensory stimuli. So we as a society have invested an enormous amount in early intervention. This can take up, for instance, in New York State, nearly half of the public health dollars. And we believe passionately in it, although the data are, I would say, mixed in terms of the efficacy of early intervention. Those of us who take care of kids with brain injuries and who study the science of brain development, we believe this very strongly, that proper interventions to help to recover movement, to help to promote language, socialization are absolutely critical. But we're largely going on a hunch. The data are sparse, but I think the key is not that the interventions don't work, but we just need the data to be able to say with some certainty this is a treatment that should be provided, and this is one that is not as effective. So we're continually looking for validation of strategies to increase brain development. So my special interest and expertise is is recovery of movement, in particular recovery of hand movement, hand function. And this is one of the more severe deficits that kids with early brain injury can have, particularly brain injury on one side of the brain. And so people have developed ways of getting kids to use the impaired hand. And the intervention on the left we call constraint-induced movement therapy, where in this toddler, her left arm is actually in a cast. This is a bivalve cast that can be easily removed. And then she's forced to use the impaired hand. Other strategies ask the child to use the hands together. So knowing that the impaired hand, this child's left hand, is more likely to be a helper hand, let's ask it to actually do the job that it's going to do, which is to help out the dominant hand. And the short word on how this works is that both are good. Both help to restore function. So here's a test of hand function. We measure the amount of time that it takes a child to do a bimanual task using both hands. And you can see that before the intervention, it was taking kids nearly 400 seconds. After an intensive camp experience, going to a camp and using either the constraint therapy or the bimanual therapy, that amount of time dropped to about 250 seconds. So it really got quite a bit better. And then if you test the hand again, the hand function again, either 1 month after or 6 months after, the effects of this intensive therapy persist. So the kids get better, and that improvement persists. So I don't want to delve too deeply into the science here, but we can test how well the brain is connected to the impaired hand, and we can do it by holding a powerful magnet over the brain and turning it on and off, and this causes the brain to be stimulated and the hand to move. And so here's a kid sitting, one of our subjects sitting in the chair watching a movie. And having this brain stimulation, and this is a picture of the child's brain, and we can look at various places in the brain where normally movement is produced and ask the question, how easy is it for the brain to produce movement? And so here's an example where this is movement produced by this brain stimulation, and after this intensive bimanual training, it's much easier to produce a movement. So what we're trying to do is we're trying to use physical therapy not just to limber muscles or keep joints from developing contractures or anything. We're actually using it to help repair connections between the parts of the brain that control the hand to actually restore control of hand movement. We can also use this type of brain stimulation to actually promote brain function itself. So in kids with weakness on one side, we measure their hand function, and the kids who receive brain stimulation can grip much harder after the intervention, whereas the kids without the intervention don't improve in terms of the grip strength. So these are just examples of ways that we've thought about either using endogenous activity, meaning practice during these intensive camp therapy sessions, or using exogenous activity in the form of electrical brain stimulation to help promote hand function and normal development. So I believe that's my last slide, and so I'll hand it over to Kelly. I'm sorry, Kelly, you're going to have to introduce yourself because I don't actually have your CV in front of me. But
I will. Thank you, Jason, very much. So I am a pediatric neuropsychologist in private practice, but equally important and perhaps more importantly, I'm a mother of 3 children, the youngest of which Jason mentioned is a preemie herself. She was born at 26 weeks. When I sat down to think about what I wanted to talk about, I wanted to look at goals for school-age children. And the things that I thought might be interesting are what are the risks associated with prematurity that might impact your child in the classroom, on the playground? What do these things look like? And if you have concerns, what should you do? Before I start talking about that, I want to sort of put it all in a context. So this is my daughter, Larissa, and this is actually kangaroo care that Jason referred to. So, you can see she was born a little less than 2 pounds. She has a beautiful head of red hair and lovely, small, delicate hands. But by being born that prematurely, she was at risk for a host of various learning issues, emotional issues, physical issues. And she herself has been evaluated several times and had different therapies. And many times we were told she could do this or couldn't do this. And I've always been shocked at how she has proved so many things wrong. This is her, a few years ago in one of her favorite pastimes, skiing. Many times we've been told certain prognostic indicators, prognoses for her, and it's really amazing to see and has really informed my own practice. So what are the risks for preemies? I've mentioned a few here. The big ones that we look at in my practice are learning disabilities, ADHD, language impairment, and mild neurological impairment. And Jason mentioned early intervention. So early intervention will be something that occurs very early on. Probably referral comes in the NICU or at a first pediatrician's office. Actually, early intervention comes out of the Individuals with Disabilities Education Act, which also serves children from school age on and actually serves many kids through high school and for some children after high school as well. So, children get picked up and receive early intervention in their homes. They often go to preschool, whether it be an integrated preschool or another preschool to receive services. And then, so what is life after early intervention when children go to school? And these are the times that subtle things, like Jason mentioned, that might not show up early on might emerge later on in kindergarten, first grade, second grade. I because of the time constraints, picked two that I think parents might be most interested in. One is just the global learning disabilities, and the second is ADHD. So learning disabilities is a fairly general term. When parents come into my office, and my assumption for almost all kids is here is a child with wonderful potential, and for whatever reason their performance in school is not reflective of that potential. So there's some barrier getting in the way of them sort of shining as brightly as they should in the classroom. Most often these things are reading, writing, listening, speaking, reasoning, doing math. And you may have heard these terms. So the common ones that you would hear would be dyslexia, which is difficulties with reading, dysgraphia, which is difficulties with writing. And in the early grades, this mostly has to do with the output. The handwriting is sloppy. They have trouble with sizing their letters. And then later on, those same skills of putting their ideas onto paper emerge. Dyscalculia is the term for difficulties with math. Learning disabilities are actually more common in the general population than many people think. 1 out of every 5 people in the United States has some diagnosis associated with learning disability, and almost 1 million children have some form of learning disability that they receive special education for, and these are numbers that come from the U.S. Department of Education. Now, of course, children that are premature are at higher risk for learning disabilities. This is a very dense slide, but I wanted to include it just for reference for you. So these are some of the things that you might see, or your pediatrician might see, or a teacher might see that brings concern. And basically what that means is that as your child enters school, that what they're doing in terms of, for instance, reading, writing, doing math, appears inconsistent with what their peers are doing, or inconsistent with what you would expect based on their own intelligence. Your child is wonderful, she learned to talk early, she is quite bright, picking up things, but yet for whatever reason, for instance, she's not breaking the code of reading in the same rate as her peers. ADHD is also quite common in the general population in the sense that it affects 3 to 10% of school-age children, more boys than girls. But like learning disabilities, children that are premature are at greater risk for a diagnosis of ADHD than their term peers. And like learning disabilities, the earlier a child is, the earlier an infant is, the greater the risk. So this was a study that was done in Sweden in 2011 looking at over 1 million births. And children that are born at 23 to 28 weeks, you can see here, have 2 times the risk of an ADHD diagnosis as compared to their peers that were born at term. 29-weekers to 32-weekers have a 60% greater chance, 33 to 4 weeks, 40%. But even these children here, the 35 to 36-weekers, their chance of prematurity is around 30% greater than their peers that reach their full gestational age. So this is just something to keep in mind when you're thinking about your child and seeing behaviors that are suggestive of attentional issues. ADHD can be somewhat confusing for parents. At one point, the diagnosis was called ADD, so attention deficit disorder, and then just really related to how we start to classify this disorder, it was the language was changed so that now it's referred to as ADHD. However, there are two subtypes of ADHD. One, best represented by this little guy here, is the kind that does where you see a hyperactivity component. So these are the children that have trouble sitting in circle time. They're up and out of their chairs. They're interrupting the teacher. They're engaging in impulsive behaviors. That child is often picked up early in school, kindergarten, first grade, second grade. However, there is another type of ADHD called predominantly inattentive type. And these children are often not identified until often middle school. So this is the child that is not up and down and moving around and calling themselves out as being inattentive. However, they're the daydreamer. They're the child that's sitting there. They're missing half the instructions because their mind is wandering. They're having difficulty with reading comprehension because, again, their mind is wandering. And these kids often don't get picked up until much later, 4th, 5th, 6th grade. Again, here's a fairly dense slide with signs of ADHD, which you can refer back to, and also resources like LD Online is a wonderful site to find out more about ADHD and learning disabilities in general. So if you have concerns, or if your pediatrician has a concern, or if a teacher reflects a concern, what can you do? Jason talked a little bit about, kind of early intervention in terms of preemies, or early birth to 3. And when kids get older, we often think early intervention and early assessment is also just as important. And for the reasons you might think, but for other reasons as well. A lot of times, kids that are in 1st, 2nd, 3rd grade, this is where foundational skills are developing. So kids are learning phonemic awareness. They're learning letter identification. They're building their math facts. And very quickly, when they hit around 4th grade, they're no longer sort of learning to read. They're reading to learn. And if children are having these foundational issues building these foundational skills, by the time they hit 4th grade, without sort of early support, they're really, most importantly, feeling bad about themselves as a learner. They're sort of, their self-esteem is impacted, and the gap between them and their peers is wider than it should be. So getting the child assessed and evaluated is probably one of the better things. Many times it's something very mild. Sometimes it's nothing. And for all of these issues, there are many, many things and interventions that we can do to, again, remove that barrier for that child so that they can access their full potential. So you can receive an evaluation within the public school system. If you, the teacher, has a concern, you can ask that your child be evaluated by your public school. This can occur for a family even if your child is in independent school. You can ask your local public school to evaluate your child. Many times people come to see private evaluators like myself. I often see kids either before they've gone to be evaluated at the school or afterwards in a consultative fashion. And I wanted to just briefly talk about things to look for in an assessment because I think that it's important because if you're going to put forth resources both in time and energy and financial resources, you want this to be a process that is very effective for you and your child. The first thing is that really an assessment does need to be comprehensive. So I listed here, these are all things that if a child was to come into my office, any child, we would take a very comprehensive look at all of these areas of functioning. Oftentimes things, for several different reasons. Oftentimes things coexist and co-inform one another, but also it's really important that you step back and you evaluate not only where the area of struggle is, but also identify where areas of strength are. The idea is that this is a comprehensive evaluation, and we all have things within our learning profiles that we do quite well, and we all have things that we do not as well or are challenges for us. And both of those are areas that need to be identified. The other thing is that it's important that the provider have expertise in the area that you're interested in. So someone who has worked, for instance, with children with ADHD, or someone who specializes in reading disabilities. In addition, many hospitals and private practices like myself are training facilities. So you want to make sure that the person that's in the room with your child, that's actually interacting with your child and assessing your child, is not necessarily just the trainee, but also the professional. The other thing is flexibility. It's very important that an individual evaluation isn't viewed as sort of, this is what we do with all children. There are many variables that go into obtaining a quality evaluation with a child. For instance, a child that is anxious, they might need to have more breaks or take things more slowly or break things up over several sessions as opposed to one long session. The same thing for a child who has attention issues. So those are important questions to ask if you have a child that has trouble sitting for a long time, if you're worried about your child's anxiety level. The other thing, again, is going back to an evaluation that's strength-based. You want your child to walk out of an evaluation feeling that they are very smart, they're very competent, and that they're ready to take on school and the world. And you need to feel like there's nothing worse than having your child be evaluated, going in and having it be very focused on whatever a particular weakness is, and walking out really feeling demoralized. Your child, we are all, more than one aspect of our profile. And so it's very important that we identify all the things that children are good at as well as all the things that are challenges for them. The last thing that's very important, I think, is a willingness to participate in follow-up. This would be, for instance, it might be very important for an evaluator to go to a school and observe your child in the classroom. It might be important for them to go and talk to teachers. Also, if, for instance, your child needs a speech and language evaluation, it's really important that you be provided with a referral and that whoever's doing that evaluation be willing to sort of match you with a good fit, who temperamentally might be a good speech therapist for your child, who is in your area, who takes your insurance. All these things are very important for an assessment to be a working document for you. And then what to do. If an area is identified as a problem, what are your options? First option, of course, is in the school. If your child is in the public school system, they can be determined to be eligible for what's an IEP, an individualized education program. And if your child is eligible for an IEP, this means that they receive direct services from the school. So, for instance, if your child is determined to have issues with reading, this might mean that he or she receives specialized instruction with a highly trained teacher in a small group for reading instruction. The other options are a 504 plan. This is something the school provides that is not direct services but provides accommodations for your child. For instance, if a child has problems with attention, then perhaps they would have preferential seating. They would be seated next to the teacher. They would be provided with movement breaks. And all these things are written as sort of a contract between you and the school that these things will happen in your child's classroom to allow him or her to succeed more smoothly. Then, of course, there's private support, which can look like many things. It can be tutoring, occupational therapy, speech and language therapy, parent training, medication. And then lastly, sometimes overlooked are other things that aren't necessarily interventions per se, therapies per se that you would take your child to, but can really make an impact on whatever issue your child might be having. Factors such as exercise, different kinds of extracurricular activities that might be fun for your child, the role of sleep, diet, relaxation, all of these sort of other things that you as a parent can do and can sort of empower your family to do to make a difference on a day-to-day basis.
Thank you so much, Dr. Lowry, and to also Dr. Wolfberg and Dr. Carmel for your excellent presentations. We have a couple more minutes for questions if anyone wants to type in a question. While you're doing that, I wanted to share links to our presenters here, and we'll also email these to you. Within a couple of days, you will get a recording of this presentation. Anyone who is participating right now or who registered and could not participate tonight will receive a recording with these links included. If you have questions, go ahead and type those in. I see a couple here. One says, first-year milestones such as smiling or walking go from corrected age, but is there any way to encourage development? My baby is 12 weeks old, 2 corrected, and waiting for that elusive first smile is killing me. Does anyone know the answer to that question?
Jason, you might be the best one.
Yeah, so this is Jason Carmel. So the sorts of things that all parents do with children to get them to respond. Obviously, one of the first things that we as humans do in terms of our milestones is to be able to regard a face and eventually to be able to smile at someone, and those are encouraged simply by providing the stimulus. And there's little that we can do beyond that. I think maintaining the overall health of the child, but providing that stimulation is basically what we can do to try and encourage that behavior. In terms of the other 1-year milestones, which is basically the things that can go from rolling to sitting to crawling to babbling, and eventually ends up when is my child going to walk and when is my child going to talk. Those are that's exactly what early intervention is targeting, is trying to figure out where your child is developmentally and try to encourage the child along that developmental process. It is true actually in this case that you have to crawl before you can walk, although not all kids crawl before they walk, but one needs to progress along that spectrum, and so working with the person who evaluates your child, you'll try to figure out what are the short-term developmental milestones that we're hoping to achieve. What are the intermediate term, and to really hone in on those skills. So those are, I think in terms of how sort of difficult the tasks should be, we in the sort of motor learning literature, we think about a sort of Goldilocks effect, which is you don't want to try to teach a 3-month-old to walk because that's too hard, and you don't want to you don't want to give them skills that they already know how to do because that's too easy. And so what we're looking for is something that will challenge the child to achieve that next developmentally appropriate skill.
Thank you, Dr. Carmel. Dr. Wolfberg, there's a question here for you. It says here, Dr. Wolfberg mentioned the March of Dimes website. The website mentions the March of Dimes Healthy Pregnancy Diet. What is the role of nutrition and maturity?
I think that nutrition is important for everybody. pregnant or not, children or adults, and nutrition is never more important than during pregnancy. I think that probably the single most important nutritional element is folate during the time that someone is trying to conceive and then early in the pregnancy in order to prevent neural tube defects. But specifically in relation to the issue of prematurity, there is a weak relationship between poor nutrition and an increased risk of prematurity. There's some research from times of great deprivation during world wars and the increased risk of prematurity during those periods. So I'm not sure that it's likely that an individual premature delivery is related to a episode of poor nutrition or generally poor nutrition during that particular pregnancy. But I do think it's important to maintain a healthy pregnancy and a healthy newborn period with the best nutrition that's possible. I hope that answers the question.
Thank you. There's another question here. It says, what do we know about the roles of breastfeeding, human milk, and pasteurized donor human milk in the long and short-term development of preterm infants? Not sure who wants to take that one.
I'll take that one. Breastfeeding is terrific. Breastfeeding is absolutely a gift that women can give to their children. And there's a growing body of evidence both in preterm infants and in full-term infants that babies and children do better in many domains if they're breastfed than if they're formula-fed. This is particularly true among preterm newborns. And in fact, there's a growing movement to make safe donor breast milk available to preterm infants in the NICU when, for whatever reason, their mother is not able to provide breast milk herself. Many women find that one of the really frustrating aspects of being a parent of a child in the NICU is how little she can do, and breastfeeding, pumping in the beginning and then breastfeeding thereafter is something that she can do. On the other hand, I really do think it cuts both ways, and there are lots of reasons why breastfeeding may be difficult or impossible. And the idea that a woman would beat herself up over the fact that she is unable to pump breast milk while her child is in the NICU is a terrible thing. Women do the best they can for their children, whether they're born prematurely or whether they're not. Some are able to breastfeed or pump, others are not. And I think you can just take great comfort and confidence that parents are doing the best for their kids.
Thank you. Dr. Carmel, there's a question here for you. Is there a clear relation between the degree of prematurity and NICU stay and the effect on the central nervous system?
Well, I think the outcomes, some of the outcomes literature that Kelly went over, in terms of risk for developmental problems, learning problems, attentional problems. There's clearly a strong relationship. The earlier that you're born, the more at risk you are for those developmental problems, and that's true for neurological problems on the more severe end of the spectrum as well. What is heartening, so whenever we talk about risk, I think it makes people afraid. For the majority of kids born premature, they will do very well, and they're more likely to be like their peers in school than they are, like many of the children who I see in the clinic. So I think that there clearly is a risk. How do you deal with that as a parent? How do you deal with the fact that you know your child's at risk for these developmental issues, I think you just do what you can as a parent, which is to offer your child a lot of love, a lot of the normal sort of developmental nudges that you do to try and get your kid to move in the way they should and interact in the way they should, speak in the way they should, and that's what one can do. Sometimes the help of early intervention or specialists to help guide a program of development can be quite helpful. But and so that's what we can do to try and nudge the process along. The greatest predictor of how a child's going to do in the future, obviously, is the early developmental trajectory. Meaning, if your child is picking their milestones up at the sort of age-adjusted rate that they should be, that's a very heartening sign and should give you comfort. And if they're not, there is time for catch-up as well. So it's true that prematurity is a risk factor, but your child is more likely to end up like the other children in the classroom than not.
Thank you. There's a question here for Dr. Wolfberg. For women at high risk for preterm labor, what is your opinion of working during pregnancy? How about resting more or bed rest?
Rest is always a good thing for anybody, pregnant or not. But bed rest and restricting activities is one of those things that we as obstetricians have always thought made a lot of sense, just because the cervix points down, and if you can take weight off of it, perhaps you could reduce the risk of preterm delivery, preterm contractions, etc. Unfortunately, there isn't any convincing evidence that bed rest or restricted activity actually makes it less likely that someone will go into labor or deliver prematurely. We do it anyway. On any given day, I have one or more patients hospitalized on bed rest and others who are at home on bed rest because it certainly isn't going to cause any harm and maybe it would help. But I wish I could say with greater confidence that it actually works, but I can't.
Thank you so much, and thanks to all three of our presenters, Dr. Wolfberg, Dr. Carmel, and Dr. Lowry. I wanted to announce, in case you didn't see it in the chat, that Nancy Holtzman will be offering a full webinar on Preemies, breastfeeding, and human milk next Thursday, November 15th at 12 noon. You can register on the IsisParenting website. You can join on the IsisParenting website. It's free. We want to thank everyone for attending. I know there were many, many questions. Sorry we couldn't get to all of them. We will be emailing you, as we mentioned, the recording along with the links to our presenters and other links to sites that may be helpful to you. I want to thank everyone for joining us tonight, and we hope to see you at another ISIS online event soon. Thank you very much. Good night.